Um, Good morning to one and all. It gives me great pleasure to invite you all for this IC on repeaters in general ophthalm. These are the frequently seen OPD revisits that we are not so happy to see actually. So let's learn from the experts how to handle them better. Is there something we can do in terms of medical or surgical management? So to start off with, we have Dr. Shweta Agarwal. She's a consultant in Shankar Netralaya. Her interest is corneal ocular surface. She's also a wonderful human being and she's ever smiling. We are, we are waiting to hear from you, ma'am. She will be telling us more about how to handle VKC patients better. Over to you, ma'am.
Thanks, Sugaranjani. As she said, I'm Shweta at from Shankar Netralaya, Chennai. And thank you so much, Sugaranjani, for making me part of this beautiful IC. Well, I'm going to be talking about vernal keratoconjunctivitis, how we can manage these patients better. Just a few disclaimers. Photographs are with permission of patients and I have no financial interests. Well, before we start the treatment, it becomes important for us to stage or grade the disease so that we can titrate our treatment accordingly. Well, Bolognese classification is something that is most commonly used, and it is based on primarily the signs and symptoms. The more severe or persistent the symptoms become, and more severe is the corneal involvement, the severe is the disease. Let me take you through a few case scenarios quickly to understand. Well, first patient, something that we are all happy to have in our clinic. These are patients who have just mild seasonal variation and they do extremely well with dual acting medications. Most of them will come and tell you that they have exacerbations during summers or winters, and what we usually advise them is to start these dual acting medications a month prior to the season that they have problems in. And during those few episodes of activity, you can give them a short course of low dose steroid. The available topical medications are these, which are most commonly used. However, the dual acting, which includes these 4 drugs, are the most commonly preferred medications because they act both as antihistaminics and mast cell stabilizers. While vasoconstrictors are out, nobody, I guess, uses it anymore. During periods of activity, you can start them on topical steroids, preferably the low dose, the low strength FML or lodipred. Now let's move on to some severe cases. These are cases where the symptoms become more persistent, the patients have papillary reaction and also superficial punctate keratitis. Now in addition to treating these patients with topical steroids and the dual acting agents, we put them on topical immunomodulator like tacrolimus or cyclosporin so that the symptoms become less frequent and the patient is a little more comfortable. Now, when we talk about topical immunomodulators, we have tacrolimus and cyclosporin, which are available in different strengths. They basically have a similar action profile. They both do cause a little bit of burning, but in children, I personally prefer to use tacrolimus because it's an ointment. It stays in the eye for a longer period, especially if you give them in the night. The 3 primary indications for use of topical immunomodulators are patients who have severe recurrent cases, persistent symptoms, you are unable to get them off topical steroids, patients who have associated complications like a limbal stem cell deficiency, keratoconus, or scars because of recurrent shield ulcers, or patients who are steroid responders. These are used as steroid sparing agents. Now moving on to another patient where he had a mixed VKC, persistent symptoms again, but this time now the patient is also presenting to you with a keratoconus. Management of keratoconus becomes extremely important in these children because these children will not tolerate a normal rigid gas permeable lens, which we otherwise advise to keratoconus patients. In addition to controlling the disease with topical immunomodulators, steroids during the activity and dual acting agents, it is important to manage their keratoconus at the early stage. Once the eye is quiet, Pachy is adequate, go ahead, do a CXL. If it's not, you can post the patient for a lamellar keratoplasty. Now this was another patient who had a severe limbal VKC and had no systemic ailments. If you can see, gradually over the periods of year 2014, we have started seeing the patient, and it's 2017-18 that we've been able to maintain his limbal stem cell deficiency without severe worsening. He's been on topical immunomodulators and olopatadine, despite which he was having recurrences. This is where the history comes into play. We realized that he had exacerbations more during summers, and whenever he would visit his grandparents on a hilly terrain, he would feel better. After counseling with the parents, they shifted him to a boarding school which was on a hill station, and it's been almost 7 years. We've been able to maintain the limbal stem cell deficiency without any surgical intervention, only on topical immunomodulator and dual-acting allergics by just shifting him to a cooler place. So take care of the inciting factor. Sometimes it is the associated systemic ailment like the atopic dermatitis in this child. So whatever you do for the shield ulcer or the giant papillae, it is not going to resolve till you have taken care of the atopic dermatitis. Here comes the role of a dermatologist who might need to start him on oral cyclosporin if it is not coming under control with topical emollients and topical immunomodulators for the dermatitis. So again, take care of the inciting factor which is causing the problem in the eye. Now this was another patient who had a very severe tarsal VKC, had no systemic complaints. We put him on maximum medical therapy. He had a recurrence of the papillae, did a cryotherapy, he had a recurrence. Then we put him on a short course of oral steroids, after which he had a recurrence. And this is when we went ahead with a mucous membrane grafting, wherein you replace the diseased tissue with an immune tolerant tissue. The more severe or the size, as the size of the papillae increases, the severe becomes the papillae. When we come to the management, we start with a supratarsal steroid, which induces a local immune paralysis. Next, if there is a recurrence, move on to cryotherapy. Oral immunosuppressives have a role primarily in patients with associated systemic allergies, so which is where you can use them. If nothing works, you can consider a mucous membrane graft. Now this is a very interesting tissue. Here what you're doing is you're replacing the diseased conjunctiva with an immune tolerant tissue. None of us routinely hear of an oral allergy, right? We do hear about ocular allergy, skin allergy, asthma, but very rarely we hear about an oral allergy. The oral mucosa is inherently immune tolerant and structurally, histologically, functionally very different from a conjunctiva. So it reduces the intensity and the frequency of episodes of disease activity in these children. Another patient, my last case, a case of very severe VKC, a mixed VKC. He was a known case of HIV since birth, but he presented to us with symptoms of VKC for the last 4 to 5 years. The CD4 counts had reduced at that time, and despite maximum medical therapy, we were not able to control until we sent him to the physicians to change and put him on a second line of heart therapy. With improvement in the CD4 counts, now his disease is very much under control. So in patients who have HIV, if you have children, make sure that the CD4 counts are stabilized before you can really have that good control of VKC. Now patients who have severe grades of VKC, but you don't know or they are not able to communicate about any known systemic ailments, you can refer them to an allergy specialist who will do a skin prick test, and if found, they might start the patient on immune therapy. Treatment, as I discussed, is based on the disease severity. To summarize, identify the stage of VKC, treat the symptoms, not the signs, look for the aggravating factors and address them, which is where the history comes into play. Consult the dermatologist or the allergy specialist for systemic allergies, and role of immunotherapy is indicated in patients who have systemic existing allergies or are allergic to some known allergens. Thank you.
Thank you so much for that wonderful talk, ma'am. We could take some questions.
It would be interesting if you can summarize on how you manage a shield ulcer. I think most of will be interested in.
Yeah, so shield ulcer, as we all know, has 3 grades. The first grade is where you just have a defect. Shield ulcer is primarily caused by a tarsal papillae. So there comes 2 factors. Like we said, there are, whenever you are managing a complication of VKC, there are multiple factors that we need to look at. One, why is the disease severe? So if you are able to identify an etiology or an underlying cause, first start with the treatment with that. Second, if it is a tarsal papillae which is causing a shield ulcer, that needs to be addressed. And then comes the shield ulcer. So shield ulcer is a symptom which has occurred because of the other 2 factors. So until unless you take care of that, you're going to keep having the shield ulcer again and again. Having said that, once you've managed those 2, if in the early stage you can just put the patient on a bandage contact lens, start them on topical steroids and your other anti-allergics. If it's a little more severe where you have a thin layer of plaque, debride the plaque, because until unless you debride the fibrinous plaque, the epithelium is not going to heal. And third, if it is really severe, you might need to put an AMT and then a bandage contact lens.
If I may, one question. What is your preferred steroid for supratarsal injections, and do you counsel the patients differently? I mean, patients, bystanders basically. Do you highlight any risk factors of this particular? How do you deliver it under topical, or all your patients are under GA? Because mostly these are kids. So
Yeah,
how
so
do you manage
it's
that?
preferably under GA because they are kids, as you rightly said, and the location, again, supratarsal is not a very convenient site to be injected upon. We usually prefer a tricot injection, and intraocular pressure spiking up is a major complication. So we do tell them that they will require a regular pressure check when we are giving a supratarsal steroid, and we are making sure that they are not steroid responders based upon the past experience or the history.
Any questions from the audience?
Do you have a circulating mic? Audiovisual?
There's a mic behind.
Okay, so can you use that, please?
Hello, ma'am. How exactly you differentiate between a KF ring in children, KF and flesh ring? How, by on slit lamp examination, how exactly you differentiate?
So, Flesher's ring, in addition, has a lot of other clinical presentation. Patients with Flesher's ring will have corneal ectasia, will have Vogt's tri. Patient will give you, the refraction. It all starts with the history. The patient will give you a problem that he's not happy with glasses. So typical symptoms of keratoconus is one that you start clinically looking at. The KF ring is something which is very, very faint. It is usually not, the patients that I have seen are not as clear and thing that you look at a Flesher's ring. Both are a little brown, but I think it is more of the associated features that you see with the Flesher's ring that helps you differentiate more. Dr. Vinay, you want to add something? Yeah, correct. Correct. They are very different. They are very different. Yeah.
Okay, KF ring you don't see on the surface unless it is very advanced, and it is not in the cornea, it is at the limbus. It starts from the deeper layers, okay, predestinate layers, and comes up. Okay, so that is the major difference. And I mean,
Because it's an iron
you have to
deposition
see-
from
yeah.
the.
Yeah, you just have to see one. You will never forget.
Yeah.
KF ring.
In the interest of time, we'll take the questions later. I would like to invite Dr. Pragnya Rao. She is a working consultant in LV Prasad. She is a rising name in dry eye management. We are all waiting to hear how Pragnya manages these dry eye patients who are very difficult to please. Over to you, Pragnya.
So, good morning, everyone. At the outset, I would really like to thank Sugaranjani and the rest of the team of KSOS for this wonderful opportunity. So, I'll basically be touching upon the approach and management for dry eye disease. I do not have any financial disclosures. And as we all know, dry eye is multifactorial. So, there's a lot of factors interplaying, and they all together culminate to create a very hostile environment. So, it can have a varied spectrum, like we can have the simple evaporative kind of dry eye, where you don't generally see much of corneal involvement, to the more severe forms where there's conjunctival inflammation, cicatrization, and more of an end-stage ocular surface disease. So traditionally, dry eyes was classified as aqueous deficient and evaporative, with aqueous deficient again classified as Sjogren dry eye, where there's systemic autoimmune disease, and then non-Sjogren dry eye. But the most recent classification has also laid a lot of importance, apart from this, on patients who are asymptomatic. That is, they have signs of dry eye but are not symptomatic. Then there's another subset where they have a lot of symptoms of dry eye but they do not have any signs. That is more in line with either neuropathic pain or pain without stain. So these are also included into the spectrum, and they need evaluation, and rather than us brushing it off saying there's no signs and symptoms, so you do not have dry eyes. So a large data set that we tried to look at, we saw that the age-related incidence of dry eye is much higher, and it was much more common in younger males, probably because of occupational risk, and also mostly in females in the 5th to 6th decade, mostly around the perimenopausal age group. also with the change in hormonal levels. And a similar study from the north also gave age, desk job, VDT use and other factors as the most common risk factors. So they had a much higher prevalence because it was symptomatology based, which again iterates that a lot of patients may experience symptoms, they may be subclinical, but they may end up developing it. So it's very important for us to assess. Also interesting that we also see this amongst children. So it's not that it's rare, but you generally have the more severe forms. But MGD was something we saw much more towards the adolescents. So all these things have been something we need to keep in mind when we are looking. But before we try to understand how we're going to manage, it's very important for us to assess the tear film structure, like the topmost lipid layer that you see, it comes from the meibomian glands. Then we have the aqueous layer that comes from the accessory and main lacrimal gland. And then we have the mucus that comes from the conjunctival goblet cells. These all work as a continuum. So we need to see and identify which of the layers is deficient or abnormal and how the patient is manifesting, which is what will guide us on how we want to treat this patient. So we will firstly want to look at the entire ocular surface, including the adnexa, the lids, whether the lids are healthy or capped meibomian glands, whether there's any keratinization. Ocular surface staining is a very important next step that we want to take, and any unexplained staining we should be suspecting dry eye, and some imaging modalities that I'll be discussing later, especially meibography, where we can pick up the dropped out meibomian glands. So the first way to assess tear film volume, so because we're talking about aqueous deficient and evaporative, we need to first assess whether there's enough volume. Schirmer's test is something which tells us about this, and anything less than 10 should be considered, or we should be alarmed and probably keep them under follow-up, but over 10 or 15 is considered normal. Next, we need to check the tear film stability, which is the tear film breakup time. So we put fluorescein, ask the patient to blink thrice, and the first dry spot that appears after the last blink is what we count. Less than 10 seconds is something we need to consider abnormal. And then we have the lacrimal gland secretions. This is something which is a surrogate to our Schirmer's, which can help us validate whether the Schirmer's is reliable or not. We ask the patient to look downwards and outwards, and that's the palpebral lobe of the lacrimal gland that we see, and you can see like seedles, the secretions keep coming out. Typically, we have 4 to 5 glands that give good flow. As we keep testing this in normal patients, we'll be able to figure out how this actually looks. And then there's again a lot of fluorescein breakup patterns that the Japanese group keeps talking about, which can probably give us an idea of which layer may be deficient. So there are a lot of tests that we've talked about, but unfortunately there's no single dry test that is diagnostic yet. It's not that we really need very huge high-end equipment to diagnose. A good clinical examination is enough. But for me, meibography is something I think is the only thing which is very important amongst all the non-invasive tests. So once we've done the test, now we want to type whether it's evaporative or aqueous deficient. In aqueous deficient, whether it's Sjogren's or non-Sjogren. In non-Sjogren, again, we can have Stevens-Johnson syndrome, ocular cicatricial pemphigoid, graft versus host disease, and drug-induced cicatrizing conjunctivitis, etc. So evaporative dry eye again forms the most common type. We typically see inferior corneal staining, capped meibomian glands, and if we do meibography, and we don't need to have a machine, any equipment with an IR camera like autorefractor or a specular can also give us a basic idea of how the meibomian glands are looking. But these patients generally have good tear volume but have a faster breakup time. And also, as we can see, with increase in severity of the disease, generally if the scans are captured well, you'll see that there's reduced lipid layer thickness and there is faster tear film breakup time. So these are the things that suggest there's evaporative dry eye. Sometimes when we have these bad eyelashes and then there's collarettes all around, demodex is something we need to suspect in these cases, because these people can have a very silent MGD dropout that can be missed, and these instruments help us pick this up. And sometimes it's ocular rosacea also, we can actually pick it up. In our pigmented skins, it's not easy to pick up ocular rosacea, but when you suspect unusual inflammation, bad meibomian glands, but then you can't really see anything on the lids, but you can see there's very, very significant dropout on the glands. And then when you probe in and you look more carefully, you may pick up this condition. So once we know that it's evaporative, we primarily want to treat them with lubricants. Here we would probably prefer something high viscous, preferably preservative free. And we also tell them about screen time, blink breaks, and exercises like blink exercises and good warm compresses and massage. Patients who don't generally respond, we would want to do something like a LipiFlow or IPL, but I would definitely run all the other steps first before going in for any of these. Then comes the more difficult type of dry eye, that is the aqueous deficient. So we can see this lady who's a 51-year-old lady, like you can see very bad surface, lusterless cornea, you can see very diffuse corneal staining, and then when you probe for history for joint pains and other things, and it's always important to run an autoimmune workup. And this patient had skyrocketing anti-CCP levels who needed systemic immunosuppression. So it's important that along with the topical lubricants, steroids, and probably topical cycloamine, it's important for us to start these patients on systemic immunosuppression. And as you can see, this is how we can transform the surface when you have systemically immunosuppressed and again given good treatment. The more difficult aqueous deficiency types to tackle are the ones which are non-Sjogren type, which have associated cicatrizing conjunctivitis. Like the first panel to the left, you have Stevens-Johnson syndrome where there's significant lid margin keratinization, limbal stem cell deficiency. In the middle, we have drug-induced pemphigoid, which is generally because of long-term use of anti-glaucoma medications. And to the other side, we have ocular mucous membrane pemphigoid, which is a progressive kind of cicatrization. It is important to identify this because these patients need long-term immunosuppressive therapy. And again, on DATs, we can actually see cicatrization along the lacrimal gland in the cicatrizing type, which can give us a clue about the etiology. So once we see conjunctival cicatrization and dry eye, it's again very important to look at all the causes and establish whether it's a progressive or non-progressive type, because it's very important for us to immunosuppress the progressive types like OCP or GVHD, because they may end up progressing faster. GVHD not always. Also sometimes cicatrization can be asymmetric, like the picture towards the right. We can see cicatrization and keratinization. We should not overlook this as just a blind eye, but also try and see if there's anything unusual. And actually the other eye of the patient, you can detailed examination shows that there's some cicatrization. So some pigmentary changes also help us pick up DICC, but these changes are much more in the inferior fornix and especially towards the punctum. But stopping the anti-glaucoma medications, putting them on oral AGMs and giving them low potent steroids can actually turn things around for them, and we may have to jump in and do valve surgeries earlier for them to control. So now once we have aqueous deficiency, again it's important to give lubricants, here probably low viscous anti-inflammatory therapy in the form of topical cyclosporine, and autoimmune workup and rheumatologist consultation is important, and that's how we would want to manage these patients. And like I said, we have a lot of medications, but we would want to look at which layer is damaged and then probably go ahead. And all the combinations we have are, we have tear substitutes which we generally give to all patients, but anti-inflammatory agents also find place both in evaporative and aqueous deficient, but more so in aqueous deficient. And then some secretagogues can be given in more severe forms of these cases. So there are some exciting emerging therapeutics, like especially for the ones who don't respond to conventional therapy, but we still need the data to come out on these to be taking them into our practice. So in a nutshell, we need to identify the type of dry eye and rule out underlying autoimmune etiology, customize the treatment based on what the patient's needs are and which layer is affected, set realistic expectations for patients, and spend a lot of chair time in counseling. Thank you.
Thank you for that illustrative talk, Dr. Pragna. I'm sure everybody has a lot of questions. We can quickly take 2-3 where I set up. I think you rightly highlighted that you need to figure out which is the layer which is causing the dry eye, and we need to move away from just using Schirmer's as a way of diagnosing dry eye, and we need to figure out, and the lacrimal gland analysis is a game changer. Even if you don't have the new tools, and just a good clinical examination can help you. And I think what you have always highlighted is a dry eye workup has to be done before you instill those Paracane drops and instill those dilating drops, because that also changes how your Schirmer's and the lacrimal gland behaves. Does anybody have some? Yeah, you can add on.
Definitely the tear volume reduces after instilling Paracane, so it's preferable to do all the non-invasive tests. And even Schirmer's, we personally prefer the Schirmer's 1, wherein it is without anesthesia, though it takes both basal and reflex, but it is something much better than Schirmer's 2. And like you said, it is very important for us to not just look at Shermer's. Typically, if some patient comes with dry eye, we would want to do Shermer's. It's normal, we say you don't have dry eye, but that patient may be actually very miserable because the tear film breakup time may be something like 3 seconds. They're not able to focus, they're not able to work. We really need to pick that up and treat them adequately, and some lipid-based therapies like the mineral oil-based drops can actually help these patients much better.
Thank you, Dr. Pragna. Any other questions? Yeah.
Ma'am, something we have heard, a Dew's layer in cornea, 6th layer of cornea. There is something called Dew's 1 and Dew's 2 concept in dry eye. What is that?
So the Dew's layer of cornea is actually not Dew's, it's Dua's layer.
Dua's.
It's actually
Dua's
called
layer.
Dua's fine layer, which is the predesmatic layer. That is not something very relevant in the context of dry eye, but more so in lamellar keratoplasty. But Dew's is the dry eye workshop, which is an international group that comes together and once every 3-4 years releases their consensus. So they have multiple papers coming out on existing literature. So the first one was in 2007, which is the Dew's one. The second one was in 2017. So they keep releasing the classification guidelines for clinical trials, and then it's like just a short book for us to read on dry eye. So if you read the latest Dew's, you'll probably get a lot of information on ongoing literature in dry eye.
Now is Dew's 2 is going on or Dew's 3?
Right now Dew's 2 is current, but probably they'll release something like Dew's 3.
How exactly you differentiate between a nociceptive pain and a neuropathic pain in a dry eye? Can you please explain this?
So like we were talking about pain without stain, so there are definitely some subset of patients who complain, who keep saying they have a lot of dry eye, but when we look at their eyes, they do not have staining. Their Shermer's looks alright, the tear film breakup is also alright, but these patients are actually quite miserable because they may be having a concept of something called neuropathic pain or pain without stain. So when we're talking about nociceptive, it means there is some pathology in the eye in terms of inflammation or something that is going to irritate the corneal nerves, and that is the reason why you perceive pain. So this is when, like for example, you have SLKC or you have dryness, you have SPKs, or you have some other inflammation ongoing which is now causing pain. But there's this other part which is called neuropathic, where there is not enough of nociceptive stimulus. That means you don't generally see an organic disease, but the patient is perceiving pain because these nerves are actually being excited with a very less stimulus. So that you can actually differentiate doing something called a Parikine stress test. You instill a Parikine, wait for 10-15 seconds. If the pain goes away, the cause is mostly peripheral nerves, but if the pain doesn't go away, the cause is mostly central. So
In
that
the
is how
interest of time, can we move on to the next presentation? You can ask your questions.
Thank you very much.
I request Dr. Sugaranjani to do the next presentation on recurrent corneal erosion. She is consultant cornea at Giridhar Eye Hospital, Cochin.
Thank you very much. Not everyone is happy to see a recurrent corneal erosion syndrome patient in our OPD. And this is because most of the patients are often frustrated by their condition and condition's lack of response to treatment. So can we treat them better? So as we all know, the pathology of this condition, that the epithelial basement membrane is very loosely adherent to the underlying layers. And how do we address, going ahead treating these patients? First, we need to address the triggers, known triggers of recurrence. The main trigger is the increased production of matrix metalloproteinases. So these are known to degrade these anchoring fibrils. So there's a study which looked at treating this increase by giving oral doxycycline. So in a patient who's complaining of frequent recurrences, probably you could give them a course of oral doxycycline, 50 to 100 milligrams BD for 1 to 2 months, and also give a topical low-dose steroid for 2 to 3 weeks to reduce their level of matrix metalloproteinases. And this is known to reduce the recurrence by almost 70% in this particular study. The second trigger, I would say, is meibomian gland dysfunction. This is all very prevalent in our population, and it is known to cause poor wound healing. It also increases matrix metalloproteinases, and it leads to formation of incompetent hemidesmosomes. So the oral doxycycline that we can give will take care of this as well, and you can advise the patient to improve their meibomian gland health as well with warm compresses and antibiotics. The third trigger is definitely the dry eye. Meibomian gland dysfunction itself is associated with an evaporative dry eye, and by just giving the patient artificial tears, you would be increasing the lubrication. And as we know, RCS is caused by the mechanical trauma and the adherence of the eyelids to the healing epithelial surface. So this would significantly improve the symptoms of the patient. So an artificial tears to reduce the evaporative dry eye caused by meibomian gland. A patient coming with frequent recurrences, one must always screen for a corneal dystrophy, as illustrated by this study, where patients with epithelial basement membrane dystrophy present with more frequent recurrences, they are more symptomatic. So always look for those fine lines in the cornea, subepithelial dots. This would indicate a corneal dystrophy, and by picking this up, you would be more prepared to see this patient more often in your OPD. Once you've addressed the triggers, you must ask yourself, is slit lamp examination enough in dealing with RCS? So historically, this is how we've been dealing with RCS. We look at them in the slit lamp. We classify the lesion as micro lesion, the first picture, or a macro lesion. Macro lesion is known to be associated with traumatic RCS, and they are known to have frequent recurrences. But is this enough? The slit lamp examination tells us only about the epithelial layer and not the layer below it. And we know that the BMBM, the Bowman's membrane base and epithelial basement membrane complex is the one which is actually the problem in RCS. So ASOCT is a boon, and it is the greatest part about ASOCT. It is so simple to interpret. The changes in the RCS patients are seen in the superior layer. So this being the epithelium, this is the basement membrane and Bowman's membrane complex, and then the stroma. All the changes are seen in this layer. So by simply getting an ASOCT of this patient, you can identify several changes which are seen in RCS patient. These are the common changes already documented in literature. That is, when a patient presents in an acute condition, they have epithelial breaks, and in a chronic condition, you would see these intraepithelial inclusion bodies which are hyperreflective, and a BM layer which is seen in the rest of the cornea would be absent in the area of RCS, and you would see a little bit of anterostromal haze in a chronic patient. So when you see these chronic changes on ASOCT, you can assume that this patient is going to have more frequent recurrences, and you could probably take up the patient for an early surgical intervention. Also, ASOCT based epithelial mapping is also a boon. So this is an epithelial mapping which can be done within 5 to 10 seconds, which maps the thickness of the epithelium in the entire area of 9 mm, and in the region of RCS, which you would see on slit lamp. Sometimes even on slit lamp, you cannot identify the area of RCS if the patient is not presenting in acute condition. On an ASOCT epithelial map, in that region you would see areas of thickening. These are known as hotspots. These have been used previously in study to delineate the area of RCS. So we even had a study in our institute where we looked at the RCS patients. The area was drawn clinically in the slit lamp. Then we scanned that particular area using ASOCT, and we also did epithelial mapping, and we did note that the hotspot is present in all. And we looked at whether it corresponded to the clinical diagram drawn in the slit lamp level in the OPD. So in our study also, we saw that these are the epithelial changes. Hyperreflectivity is seen, detachment of the epithelium, epithelial edema, and also intraepithelial inclusion bodies. So it's not only reported in literature, we saw it in our OPD as well. And in the BMBM changes, BMBM layer which is seen in the other areas is defective in the area of RCS, and and it can also be hyperreflective in the region of RCS. And as illustrated already, anterior stromal scarring is seen in patients with RCS. So, and coming to the epithelial mapping, we did it in the patients. Hotspot was seen in the region of RCS. Sometimes it even helped us to pick up the region which was not seen on slit lamp, and we even looked at whether it corresponded to the diagram. So in our study, we noted that epithelial and BM changes were seen in majority of them, but stroma changes were seen in only a few. And a hotspot was seen in more than 90% of patients with RCS, and not only was it seen, it corresponded well to the clinical diagram. So it can help you pick out the exact area of loose epithelium. And when we compared them between patients complaining of frequent recurrences and rare recurrences, only BMBM changes were statistically significant. So probably this could be a predictor of recurrence. And in an RCS patient, if you do see a BMBM changes, you would like to counsel that patient earlier on for a surgical management. So coming to medical management, the common question in all our mind or our favorite drug is Hypersol. Is Hypersol all we have? So this is a study which looked at whether you should actually look at or give the patient Hypersol or a lubricant gel at night, and this study concluded that it does not really matter whether you give a Hypersol or a lubricant gel at night, and both have like equal efficacy. But if you are planning to put the patient on any of these eye ointment, it has to be done at least for a year, illustrated by the study, and then assess whether the patient can be withdrawn from the drug. Most of the times they do complain of recurrences, and sodium chloride ointment is my preferred choice. And the other line of management is bandage contact lenses. So do they really give an advantage? So the study looked at whether contact lenses give an advantage over the lubricant ointment. This study showed that there was no proven benefit of this ointment or using a BCL over an ointment. In fact, BCLs increase the infection risk. You must always assess the commitment of the patient to come back to you every month for a BCL exchange, and as long as a BCL is in the patient's eye, you must put the patient on an antibiotic prophylaxis. Surgical management, I know it is a very tempting feeling to scrape off all the epithelium on the slit lamp itself, but this debridement of loose epithelium has shown to increase the recurrences, so always refrain from mechanical debridement. And anterior stromal puncture, I think, has fallen out of favor. It does induce a lot of glare and halos in the patient. If at all you have to do it only for a peripheral lesion and not that is in the visual acuity, and they work better for a post-traumatic origin. And it's not favored anymore. So the most recent ones are phototherapeutic keratectomy. That is, you use a laser to smoothen the surface and lets the healing epithelium grow faster. But this does cause a hyperophic. I'll just be taking 2 more minutes. It causes a hyperophic shift. The patient can complain of visual symptoms. It does induce a haze, and as we know, LASIK patients as such complain of RCS, so we may be inducing more RCS. But it is known to reduce the recurrence, but you must be aware of the disadvantages, and it is also an expensive treatment. And the other option is a diamond burr polishing. Compared to PTK, it is an inexpensive technique. It does induce a haze. It reduces recurrence. But so now we know that the haze is present in both a phototherapeutic keratectomy and diamond burr. So what would you choose? So this is a study which looked at both, and the study concluded that both are comparable. They do induce a haze of 26%, but are successful in reducing the recurrences. But a diamond burr treatment would be an in-office procedure and inexpensive to the patient, so probably that would be your first line. So our preferred technique is an alcohol delamination of the cornea. This is a study by Dua et al. Which reported 92% less recurrences. Why is this so favored? Because it's inexpensive. It does not handle the Bowman's, it does not disrupt the Bowman's layer at all, so it does not induce any haze. And also the removed epithelium can be used for histopathological studies. So what do we prefer? We propose that along with your slit lamp examination, add in an epithelial mapping to delineate the area well. Send the patient for an ASOCT scanning to delineate which layer of the epithelium is in, layer of the cornea is involved. If a BMBM change is noted, take them for early surgical intervention. Start with the topical lubrication, teardrops or an ointment at night. Switch over to BCL if you know your patient is committed to you. Refrain from mechanical debridement and anterior stromal puncture at all costs. And among the surgical mode of treatment, alcohol delamination is preferred over diamond burr because it's less expensive, and then PTK. Thank you for your patient listening. Any questions we can take at the end of the session. I would like to invite Dr. Mariam Pauli ma'am. She's the oculoplastic consultant at Giridhar Eye Hospital, and she'll be talking about superior limbic keratoconjunctivitis. Over to you, ma'am.
Good morning, all. At the outset, let me thank Dr. Sugaranjani for giving me this opportunity. Actually, I'm going to speak about SLKC, that is superior limbic keratoconjunctivitis. It is primarily the summary of what we have heard from all the other 3 talks. Slide. So basically, I'm speaking about my approach and the treatment protocol. As we know, it's a disease of unknown etiology, where we can see there's a papillary reaction of the upper tarsal conjunctiva. Then there is inflammation and redundancy of upper bulbar conjunctiva. So that is very, very important. That is inflammation plus redundancy, because in there is, you can get confused with conjunctiva chelosis. In conjunctiva chelosis, the whole conjunctiva is loose. Then there are various staining patterns. Then superior limbal thickening. You can see the limbus thickening. Then superficial punctate keratitis of the upper cornea and filaments at the superior limbus or upper cornea. So basically here there are three components, that is tarsus, then bulbar conjunctiva, limbus and cornea, superior cornea. Coming to the risk factors, females more prone. Thyroid disease, which I would like to stress. In fact, the studies show 50% of SLKC can have thyroid disease. When the patient presents to an ophthalmologist, they are coming for chronic ocular surface irritation. So they will never say history of dysthyroidism, hyper, whatever. So it's always our responsibility to specifically ask them, are you taking any thyroid medicines or have you been treated for thyroid? Most of the time, what I have seen is they have taken thyroid medications, but practically they have stopped. So again, they've gone for hyper. Then dry eye disease, then ocular GVHD, then conjunctival chelosis, then contact lens, chronic contact lens wearers, and various eyelid disorders. The most common is in ptosis. Majority of the ptosis patients, they come with irritation, foreign body sensation. When you invert the lid and when you see the bulbar conjunctiva, we can have features of SLKC. Diagnosis is always clinical. That's the most important thing. When the patient presents to our OPD, we will just see the slit lamp, give lubricants and send them home. But always invert the upper tarsal conjunctiva and see the superior bulbar conjunctiva. When there is filaments, we will do everything. But the clinical examination is very, very important, and it is underdiagnosed or misdiagnosed, I don't know. Coming to the treatment part, so from the history, it can be dry, you will get confused with dry eye, but if you don't specifically look for SLKC, you might miss. So when will you treat? Asymptomatic SLK, no treatment is required, but you can see, despite chronic symptoms and recurrence should dictate the therapy for SLKC. The aim of the treatment is to reduce mechanical friction and ocular surface irritation. So there is a battalion of treatment modalities, medical, surgical, all the medicines in ophthalmology other than anti-glaucoma medications, it's used in all this treatment. Yeah, okay. So now we'll just go. What is the mechanism? Lubricants we are already using. Steroids also we are already using. Then this I'm not going into the details. Then bandage contact lens, botulinum toxin. Punctal occlusion, part of dry eye, SLKC, cyclosporin, everything I have heard. We have heard from all the other speakers. Oral doxycycline also we have heard about it. It upregulates MMB, it counteracts MMB upregulation. So I will just share one of our study which which we have done in our institute. We basically studied all the thyroid eye disease patients. So in the 5-year data, we had around 3 incidents of 3% in thyroid eye disease patients, and we had 7 patients. And the most funniest thing is they have got out of the 7, 5 were dysthyroid, that is either hyper or hypo, and all majority were bilateral. So this was the treatment modality which was used in our case. All the patients received lubricants and steroids. Then 1 patient received bandage contact lens, and 3 patients received N-acetylcysteine or cyclosporin. This will come later. And this is the most important thing. We have to really educate the patient, because this is not a disease put drops, improve and disappear. Not like that. They can have multiple recurrences, and the disease will stay a very long time. Sometimes it will take 1 year to at least to settle, sometimes 3 months. So the main messages from our studies, always gradually taper the steroids. Initially we try to taper weekly and see whether she is getting recurrences. If getting recurrences, then taper very slowly over a period of 2 to 3 months. But we have to be very careful. We have to educate the patient. If the patient is not willing for follow-up, you have to be very careful with the starting low-dose steroids for long term, like 2 to 3 months. Second line in treatment is in putting bandage contact lens. We have already heard from Dr. Sugaranjani. Again, it needs lots of patient education. The N-acetylcysteine drops. This is very useful. N-acetylcysteine respiratory solution is available. That is 200 milligram per ml. That can be diluted with the artificial tears, and that to 10%. And that can be used 4 times per day for 2 to 3 months. So this is actually very useful, found to be very useful in our study. And all the patients had thyroid eye disease also. Then cyclosporin, which is already been using. So once the medical therapy fails, like multiple recurrences, patient is not willing for follow-up, patient is not very keen on putting bandage contact lens, you can think about surgical therapy. But this also you have to educate them. This is not the endpoint, still they can get recurrences. So conjunctival resection with or without tissue graft, that is just resecting the conjunctiva of the superior bulbar conjunctiva. How it works, we know there's an abnormally elevated bulbar conjunctiva. It can cause a foreign body sensation and cause inadequate wetting of superior cornea by tear filling. So this, either you can cover that resected area with an amniotic membrane graft, or you can put an autograft also. Second is cauterization. This is the very useful procedure which everybody can do in our clinical practice. This is the thermal cauterization, around 30 to 50 burns to the superior bulbar conjunctiva between 10 to 2 o'clock, up to 8 millimeter posterior to the limbus. Here the mechanism is, it increases the vascularity, epithelial cell production and globular cell density, and decreases the redundancy of the conjunctiva and increases the conjunctival fixation to the sclera. So this procedure is a very minor procedure, can just a regular cautery is needed, it can be done under topical anesthesia. Cryo, liquid nitrogen cryo, again it creates a scar between the superior bulbar conjunctiva and tenon capsule and reduces the amount of abnormal conjunctiva. So these are the few things in nutshell. The main thing to conclude, main thing is what from my experience you have to really educate the patient, then identify the risk factors. Majority of the patients, 50% of SLKC will have thyroid eye disease. So you have to really look into even if the patient is euthyroid, you have look for TSH receptor antibodies. Sometimes the antibodies will be positive. Steroids, lubricants, the mainstay of treatment. Step up the therapy and bandage contact lens, surgical option in multiple recurrences. Thank you so much.
Thank you for that wonderful talk, ma'am. I think what you highlighted about the TSH receptor antibody is very important. We get only the T3, T4 TSH and then dispose the patient saying you don't have a thyroid dysfunction. That's important. Any questions can be taken at this point for any of the speakers? Sir, you have a question?
I have a question for you. Actually, it's very interesting study that you have done ASOCT in the recurrent corneal erosion. Most of the time we are unable to do it because they are having pain, the inflamed. So at what point of time you are doing the ASOCT and
all the patient
interval?
at presentation, sir. This particular study was done at presentation. Even most of them did have pain unless there was loose corneal epithelium flapping and they could not open their eyes at all. We did instill a drop of paracaine and we did the study. This was at presentation.
Okay. And haze regarding the burr polishing, I also
yeah,
often...
I wanted to know your...
yeah, I also
know it's
often
your
see it in the literature, but now I think I started burr polishing only recently, but nearly 100 eyes I have done. I have not seen any haze. So initially I was little skeptical about doing it in the central cornea, but nowadays I am doing it in the central cornea. I am not seeing any haze for this thing. I don't know, but I also often read it in literature. Any other experience? And to Dr. Pragya, I was asking, like, are you using secretagogues really in clinical practice, or it's just in the theory thing?
So probably a lot of the Sjogren patients who are like borderline, oral secretagogues in the form of pilocarpine is something either the rheumatologist starts or sometimes we start. The main issue is tolerance because they have all these other parasymptomatic symptoms, like they have increased sweating and they have flushes. So that is the reason why some don't tolerate. But if we push them to kind of use it for a couple of weeks, then I've seen that the patients now tolerate it better, or I give them like probably a lesser dose, and then once they're used to it, it depends. The patient is a little comfortable, they don't want to take the pain. But if they have very severe aqueous deficiency, then they sometimes feel very happy about the tearing in the eye.
I have one question for Dr. Pragna, probably the last question. These IT professionals which come to us, I'm sure everybody wants to know, what do you tell them differently? Like,
so
do they feel more satisfied to see the array of tests that they do? Does it like help them in their symptomatic relief?
So
what has your experience been?
So the tests actually are quite useful for us to show them some evidence. Otherwise, they're not very convinced. But we can definitely pick up everything on the clinical examination. But I just tell them, like, you can't just run 10 kilometers just in a day. So you can't also work 12 hours on a screen just in a day. You need to slowly build your stamina to tolerate screen. So keep taking breaks, do everything possible. And then, spend a lot of chair time actually.
I think one other important part is sometimes on orthoptics evaluation in these patients. Sometimes they don't have dry eye, it is just the strain because of an orthoptics issue. So just that can make a difference.
That I think is a very important point. Somehow with the noise created, or I don't know if that's the kind of awareness, everybody labels their symptom as dry eye. So the first thing I generally ask in the clinic is, what do you think is dry eye? And half the patients get filtered out at that question only, because they're thinking of something else as dry eye.
Okay, I would like to thank all the speakers and the audience and the panelists for, for this wonderful session. Thank you so much. Thank you so much.